Oh, I'll be brave if you're brave. Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Many apologies for the delay. As we all know, coming out of COVID, technical delays are sort of a thing these days. So welcome to those of you who are able to join us today during our Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer. And for those of you who aren't, but I think most of you probably are familiar with this program, it really is a support and education program and series created specifically with people living with lung cancer and their caregivers in mind. The goal really is to bring to you live and in real time educational talks from key opinion leaders in the lung cancer community, and really in a format and in a language that's so easy to understand. I know none of you are strangers to Dr. Google and the challenge that comes with what you're trying to decipher and read when you do that. So it is really one of our main goals at this programming. We encourage those of you watching live to go ahead and use the comment box and submit any questions you might have to our panelists during this program. That's why they're here. They are here to support you and the questions that you might have as we're talking. Tonight we have with us Dr. Anthony LANFRANCO, who is the Director of Interventional Pulmonology Fellowship Program, Section of I am tongue-tied today. Section of Interventional Pulmonology and Thoracic Oncology at the University of Pennsylvania, and our very own, no stranger to this organization or to talking on the behalf of GoTo and or people living with lung cancer, TERRI JULIO, who is a 17-year survivor, advocate, and GoTo Foundation National Ambassador Council member. So welcome to both of you. I think tonight most of you have seen the topic and what we're going to be talking about, and it's really about understanding nodules, lung nodules. And I think a really important place for us to start is sort of this introduction to a nodule. What are they? What causes them? How do we monitor and treat them? Nodules are found during screening, early diagnosis, incidental findings, progression of disease. So we're going to dig a little bit deeper and talk about, how common they are and what causes them. Before we jump into that, I will ask, and we'll start with you, Dr. LANFRANCO, for us to tell the audience a little bit about you, why lung cancer is one of your primary areas of focus, and a little bit about what you do.
Yeah, so I sort of stumbled into interventional pulmonology. I didn't realize that it would become one of my passions and that I would be so involved with lung cancer when I started on my training journey. But really over the course of, now a couple of decades, meeting, hundreds, I don't know if I'm in the thousands of patients yet, but hearing their stories and helping them through their process has just been incredibly rewarding for me. And so that's what I spend most of my days in clinic or in the Bronx suite, thinking about diagnosing, treating lung cancer. And it really has just become a huge part of my life and really something I'm very passionate about.
That's amazing. And we cannot thank you enough for being here today to have this conversation and share all of your knowledge with our patient community. TERRI, how about you? I know a lot of people may or may not have heard your story, and it's quite an extraordinary story. But if we could start maybe at the beginning and then a little bit further into the conversation, where I know a lot of things will become relevant to your personal sort of navigation of this, we'll kind of fill out the rest. But if you wouldn't mind starting a little bit about you and who you are.
Sure. Well, first I'll say I am lucky enough to have Dr. LANFRANCO as my pulmonologist. So his passion comes through to his patients. I am, in a nutshell, a 3-time lung cancer survivor, and I'm also a member of a multi-generational lung cancer family. There are 6 of us in my family that were diagnosed. 2 of us survived the disease. 2 of us were diagnosed early. So my first nodule was found in the emergency room. It was an incidental pulmonary nodule that was watched. And I know we're going to get into the rest of my story later on in the program. But I've had the unique perspective of being a patient and a caregiver. My sister and I together were my mother's caregiver. I was also along with my sister, my aunt's caregiver. And all of us handled how we work with our medical team a little differently. We were all a different type of patient. So it was interesting to watch how much my mother wanted to be involved or not be involved, and the same with my aunt. So I've, over the past 17 years, had a lot of experience in the lung cancer space.
Yeah, that's actually quite an understatement, but yes, you have. And thank you so much, TERRI Ann, for being here to share your story with us and with this community, where hopefully those watching either live or post-live will be able to glean insights into their own sort of story and what that does and or should look like. So before we jump into the questions that are going to kind of lead us into this whole conversation, I mentioned, and TERRI Ann, you mentioned incidental nodules. So when we say something was incidentally found, I think we know when we're talking about screening, if something is found, then that makes sense. It was found through screening. When you've already been diagnosed and maybe your cancer progresses and a new nodule is found, that I think tends to make a little more sense. But when we talk about this incidental space, Dr. LANFRANCO, can you just really quick give us a sort of overview of what we mean when we say that?
Yeah, absolutely. So an incidental finding like a nodule is usually happening when you're getting a CAT scan for some other reason. So you go to the ER because you've got a fever and chills and are short of breath, and they do a CAT scan, looking for pneumonia, or you've got chest pain and they're looking for a pulmonary embolism. And we're doing more and more CAT scans now than we did, 20 years ago. And so we're finding all of these things that we didn't know about 20 years ago that people were walking around with. And we call them incidental findings. We sometimes call them incidentalomas, or just, things that we discover accidentally when we're evaluating other things.
Sorry, I put myself on pause so you all wouldn't have to hear me cough. I have a tickle in my throat. Thank you. I think that's important because it's one of those sort of bites, I guess, that GoTo is really interested in pursuing and growing programs around these incidental nodules, because quite often those are ones that go missed for a potential lung cancer diagnosis. You're in there because you broke a leg, or to your point, somebody thinks you might have pneumonia. Good news is you don't have pneumonia. Bad news is you did have a nodule that nobody really picked up on, and you walked out the door sort of, without knowing really what was going on. So thank you for that overview. And now I'm kind of excited to jump into just sort of nodule 101. I think quite often in the healthcare space, particularly when we're talking to our patient community, either those at risk or those diagnosed, we tend to use words that we just assume people are going to understand, or that everyone's going to understand, that it's just a universal knowing, I guess, if you will. So when we're talking about, well, you know what? I'm going to stop. Sorry, pause. I'm going to step back and say, as an interventional pulmonologist, what role do you play in screening, detection, and even treatment of lung cancer? And then we'll jump into sort of this 101.
So as an interventional pulmonologist, I'm kind of at the intersection of a lot of those things. So I am part of a lung nodule or lung cancer screening program. I am obviously diagnosing lung cancers. I see a lot of patients that come, just like you mentioned, they go to the ER and they get a CAT scan and somebody didn't miss it, and they get sent to evaluate lung nodules. So it really, being a trained pulmonologist that does advanced diagnostics kind of puts me in this unique position where I'm kind of I'm oftentimes one of the first people that patients interface with when they have a lung nodule. It's not always that way. A lot of people can get in the door through thoracic surgery or through medical oncology, less often radiation oncology, but a lot of patients wind up coming through their pulmonologists and their pulmonologists. And so I'm kind of right at the junction of where they all meet.
Yeah, thank you. Oh, go ahead. Sorry.
I was just going to say, and then once a patient has lung cancer, I often function as sort of or I try to at least try to function as kind of an advisor to help them get to the right places. So once we diagnose a lung nodule as a cancer, then I have discussions about, okay, what comes next? Do we talk to a surgeon? Do we talk to the medical oncologist? Do we talk to a radiation oncologist? Do we talk to all three? And really trying to help the patient find a treatment path that makes sense for their disease, but also for themselves personally and where they're at in their life.
Yeah, I think what I was going to say before I so rudely interrupted you was that I want to put sort of an asterisk and like an exclamation point at the end of your role in all of this, because I think far too often, particularly in some of the smaller community settings, the pulmonologist is sort of an afterthought, if you will, if it's even a thought at all, when we're talking about the team of healthcare providers that are looking at diagnosing and treating lung cancer patients. And you play such an important role, not just during or upfront with screening and diagnosis, but to your point, in that sort of decision making process about treatment options, and then really, as an adjunct to that, just pulmonary health in general, right? We know that if somebody's diagnosed with lung cancer, there is disease in their lungs, thereby they need help from a lung specialist. And I think a lot of people sort of miss that and just assume, well, pulmonologists are the guys that if I or someone I know has asthma, for example, maybe that's someone you go see. But it's so much bigger. So hence the sort of asterisks and exclamation point. Okay, without any further ado, this lung nodule 101. When we say lung nodules, do they go by other names, for one? Because I think that's another mistake we make when we're, putting information out there to the masses, is using multiple names that really mean the same thing. So what are lung nodules?
I like that you say that they're called different things, because I hear lots of different things. So lung nodules, spots, growths, masses, all these words that can kind of get lumped into the lung nodule realm. Really, what lung nodules are, if you're looking at a CAT scan, we'll put up some CAT scans in a couple of minutes, but if you're looking at a CAT scan of the lungs, one of the things that's really apparent is that the lungs don't have much density to them. They're filled with air. And so if you have something growing there that doesn't belong, it shows up apparently as a density, because cell growth is dense. And so that's typically what a lung nodule is. It's some type of cell growth. And it doesn't have to be cancer, by the way. Some type of cell growth. It's just more dense than the surrounding lung tissue, and therefore we can see it on the CAT scan. That's sort of the basic premise of the lung nodule.
Yeah, and I love that you said, and I know we're going to kind of deep dive into this a little bit later, that you said that not all lung nodules are cancerous, because I think, well, my personal opinion, take it for what it is, when I look at the current qualifying criteria for screening for lung cancer, we know we can do better. We know we need to expand that screening criteria. But even based on what we have now, a very small percentage of folks who currently qualify are actually getting treated. And I think there's this fear right? Like, what if they find something? And I think it's really important to point out, particularly in the qualifying criteria, like age range, nodules are not uncommon, even benign ones, right? So
Yeah,
to kind of like quell
yeah,
that fear going in. Go ahead.
yeah. So I like to tell folks when I'm first meeting them that if I were to take 100 people walking off the street, maybe not right in front of where I work, but somewhere down the block, and I put those 100 people in a CAT scanner, 20 or 30 of them would have some form of a nodule, and almost none of them would be cancer. So that's
Yeah.
especially true if you live in Philadelphia or other post-industrial places.
Yeah.
But they're very, and if you're in the Midwest, like the Mississippi River Valley, there's an endemic fungus there. Nodule, virtually everybody has a nodule there because of this fungus. So not all nodules are cancer, and I think that's really important to know. Because
Thank you.
back to your point, a lot of people are afraid of getting screened because they jump to the conclusion that if they have a lung nodule, they have lung cancer, and that's not necessarily true.
Yeah, agreed. And I know, Terry Ann, once we kind of get through, sort of the what lung nodules look like, what the differences are, I'm really excited for you to share your story and from your perspective, because I know you've had a lot of monitoring and following up and the fear that's sort of associated with that. But before we jump into that, so okay, we've decided that not all lung, we know what a lung nodule is, right? It's an abnormal spot, for lack of a better term, or just to keep it simple, that's on the lung that is found typically during a CAT scan. So now we've identified a nodule. What are we looking for when we're viewing the nodules? We know they're not all alike. So what are some of the differences that we see in these lung nodules?
Great question. So what I'm doing when I'm looking at a lung nodule is I'm trying to figure out the probability that that lung nodule represents a cancer. And so essentially what I'm doing is pattern recognition. And so the patterns that I'm looking for cancer are things like size, whether what the edges of the nodule look like. So lung cancers especially are usually what's called spiculated. So they've got sort of these tendrils that come off of them and stick out into the surrounding lung. You We also talk in terms of margin, we also talk about lobulated or smooth, and that can give you clues about other processes that can be causing the lung nodule, whether that's an endemic fungus or whether that's a cancer coming from somewhere else in the body. Those can be clues. The density of the nodule is important. So there's the way that x-rays work is it really is all about density. So you can have nodules that are very dense, and you can also have nodules that aren't dense at all and show up as ground glass, which doesn't mean you have ground glass in your lung. It's just some guy back in the day was describing CAT scans that thought it was, looked like if you ground up glass and tried to look through it. And then there's benign tumors too that can have like less dense centers to them. They can actually have what we call fat density. So, fat in your body has a specific density on CT scans. And sometimes nodules will have fat density in them. And that's indicative of a benign growth in the lungs. And so density is also very important. And then in addition to, size, knowing what it's doing over time. So a lot of times if a patient's coming to me the first time, with a CAT scan, I'm actually looking back at old scans to see if there was something in that spot before. And because that, if you had a scan 3 months ago and there's nothing there, and you have a scan, today and there's a big nodule there, it's probably not cancer. Cancers don't usually grow that fast. But if you come to see me and you've got a nodule on a CAT scan you had today, look back, 2 years ago on a CAT scan of your belly that happened to pick up part of your lung, and I see a tiny nodule there that nobody saw, nobody noticed, then I'm more suspicious and the probability of a cancer climbs, it goes up. So I'm going to be more concerned.
So I just want to kind of recap what you said. So we've decided what lung nodules are, and I'm restating all this because I think it's so important. There's such a misconception about there. Abnormal spots in the lung, not always cancerous. Some are non-cancerous. Lesions, spots, growths, nodules, tumors, and on down the road. When we're looking at and viewing nodules, there are four sort of main things that your healthcare provider, such as a Dr. LANFRANCO, radiologists, and others may be looking at to determine what next steps will be, right? So we're looking at the margins, as he explained, the spiculated sort of spiky ones, smooth and lobulated. Density, like what does that lesion look like? Size, how big is it? And consistency, so the ground glass part. And I loved your I guess I never really thought about where ground glass came from, so I appreciated your description of it. Part solid or solid. So those four things often, if I'm correct, lead you to what are next steps? Because we know next steps are sometimes we go to a biopsy and sometimes we just go to monitoring and follow up. So what else might you be looking at, or how does that decision made? Is it really just based on those four things, or is there larger conversations? I don't know the answer to this, which is why I'm asking.
What those four things help me discern the probability of a lung cancer. And as the probability of a cancer increases, the more likely I am to recommend some intervention. And I know we're going to talk about interventions in a little bit, so I'm going to leave that on the table for now. But that's really what I'm trying to do. Is I'm trying to pin down what the probability of cancer is. And if the probability is high, we're going to act. We're going to do something. If the probability is low, we probably won't do much of anything. If the probability is somewhere kind of like, I'm not sure, but it's, relatively low, we're just going to watch.
That's great. And I think what I'd like to do now is maybe bring up some of those slides one at a time so we can get sort of a visual. I don't know about folks watching or those on the panel, but I am a very visual person. So if we can bring up one of those slides and start, and we'll just run through 1, 2, 3. And if you can kind of describe where in the lung or where in the image we are looking and what we're looking at, I think that might be helpful for some of these folks.
Yeah, great. So I wish I had a pointer that I could point at things for you, but so right in the center of this CAT scan is a lobulated nodule. You can see it's surrounded by lung. The lung is all the dark, sort of hazy stuff, and there's little white dots and squiggly white lines, which are blood vessels. And then on the right, you see there's some white, sort of almost oval or oblong shaped things. Those are ribs. And then bottom left, white thing is a vertebral body, so backbone, basically. Now this nodule right in the middle is sitting at the very bottom of the left lung. And I would describe this as a dense nodule, and I would call it lobulated. So you can see that it's not perfectly round, it's not spiculated, so it doesn't have a bunch of tendrils coming off of it, but it's got sort of these lobes on it. So if you look at the sort of the left-sided aspect of it, you'll see there's kind of a lobe there, and then as you go around the edge of it, you'll see there's like these little sort of rounded protrusions that come out of it. And so that's a lobulated nodule. This is probably a metastatic thyroid cancer, actually. So just to give you a sense of what these nodules are, I'll give you, if I know what the answer is, I'll tell it to you. I don't think I'm watching any of these currently, so.
Rocky, next slide.
This is a cross section through the bottom of a patient's chest. On the left, you have the right lung, because we're sitting at the patient's feet looking up towards their head. And on the right side of the screen, you have their left lung. So it's a little bit confusing. Again, you'll notice the lungs are mostly dark because they're mostly filled with air, and the lung tissue itself is not very dense. Lots of little dots, little white dots, those are blood vessels. In the center of the lung, on the right lung that's on our left, sorry to be confusing, but in the center of that, you'll see there's this round, sort of hazy nodule. Or um, finding, and in the very center of that is another sort of solid-looking dot. So this is actually something called Adenocarcinoma spectrum lesion. Sometimes people call these part solid, mixed attenuation nodules, several different names to them. But this is a nodule that is highly suspicious for a type of lung cancer. And this patient was referred to surgery because the probability is so high.
Next, Rocky.
And this one, if you look at the edges of this nodule, you'll see that it looks like it's got little hairs or spikes sticking out of it. That's a spiculated nodule, and this is in the bottom of a right lung. This person also has a lot of emphysema. And this person is, their emphysema makes not a surgery candidate. And so we're looking to treat this with radiation.
That's great. Then we can go back main screen. Yeah. So I think hopefully that was helpful. And when we go to edit this down, I promise through the miracle of editing and all of the great things that happened on the back end of this, we will go ahead and circle and do arrows to make sure that folks are really understanding what those descriptions were referring to. So the nodules found, some of the above 4 sort of criteria determined. At what point is the determination, follow-up, and monitoring versus going straight to something like a biopsy? And then I'm going to ask Terri-Ann for you to jump in, because I know this has been a decision point for you on more than one occasion.
Yeah, so the decision to do something can be a complex decision. And there's lots of different variables that play into that decision. Nodule growth, nodule density, what the margins look like, just like we've been talking about. All those things play a role. And then what's also really important is the time, if the nodule changing over time and how much time. And there comes a point when the probability of cancer just gets to a point where you have to do something. And so that something is, do we want to go there yet, or are we talking about monitoring? I'm sorry, I kind of lost track there. So if it's high, we'll talk about biopsy in a second. But if the probability is low, I think we wanted to talk about this. The probability is low, we oftentimes recommend monitoring, and those follow-up scans are really important because, like I was just about to get into, change over time helps us decide how aggressive to be with a nodule. And so if if you've got a nodule that you discover and the doc says, you know what, I'm not sure what this is, but I'm concerned, you need another CAT scan in 3 months or 6 months, that's not a finding that you want to say, it's probably nothing, I'll come back in a year. Because in a year, that thing can be much bigger and it can actually change your treatment and your prognosis significantly. So it's really important to, if you're given advice to monitor a nodule, to follow up on that advice.
Yeah,
Okay.
I think that, and I think this is where Terri-Ann comes in, because I really think this is an important place for you, Terri-Ann, to talk about how exactly what Dr. LANFRANCO is talking about right now has impacted this process for you, from going from monitoring to, okay, now we need to do something. And I don't want you just to share your story, if you wouldn't mind. Talk a little bit about maybe some struggles that you may have had with uncertainty and worry that comes with the waiting part. Because I think a lot of times it's hard for folks to say, okay, I just want to go ahead and watch and wait, instead of, no, 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 I want you to get in right now and see what it is I'm dealing with. So I'm going to turn over to you to share your experience with the community.
Okay, thank you. I think what Dr. LANFRANCO said about following the advice that you're given is critical. Had I not done that 19 years ago, my outcome could have been completely different. So even though I was technically diagnosed 17 years ago, I was 42 years old. They found an incidental pulmonary nodule in the emergency room. I was admitted to the hospital because more for my heart. No one thought this thing in my lung was anything. So after a few days in the hospital, I'm released. They say, we want you to watch this. Come back in 6 months. And I'm glad I did. We watched it. I got scanned every 6 months for 2 years. At the 2-year mark is when I was told if nothing's changed, I'd be released from my pulmonologist care. At that time, I was going to a different pulmonologist. But at the 2-year mark, my tumor changed and it grew and it became more dense. And I was sent to a thoracic surgeon. The thoracic surgeon, and I think the reason that my first nodule was a wait and see is because no one thought, even when I went into surgery, that this was malignant. They thought it was most likely benign. So they were going to wedge it out, biopsy it while I was on the table, and if it was malignant, they would remove the lobe of my lung. So I woke up without the lower right lobe of my lung because it was malignant. From there, I was watched. So first it was 3 months, then it was scanned every 6 months. And then after 5 years, it went to every year. And I'll say during this time, my mother was diagnosed with lung cancer in an identical way. She went to the emergency room with chest pains. They found her lung cancer. They found a tumor. Only hers, they acted on right away. Hers was stage 3. So, and I'll just want to add this part of my story because it's pretty miraculous for the rest of my family. She told her doctor about me, and my case was unusual because of my age. We know that that's not quite as unusual as today as it was 19 years ago. So they recommended that the rest of the family be screened. And we then later found out her sister and her brother also had lung cancer. So, so after that experience, then, my sister and I helped my mother go through her treatment plan, and I was still being scanned at this point every year. So my pulmonologist left clinical medicine, and my uncle was going to Penn to Dr. LANFRANCO, and he recommended that I go see him. And now at this point, I'm on annual x-rays. So Dr. LANFRANCO orders a CT scan, because what I did learn is you can't really tell from an x-ray as well as you can from a CT scan. That was another important point. I think it's very important for people to know that for your own advocacy purposes, ask for CT scans. So my very first meeting with Dr. LANFRANCO, he had the pleasure of telling me I had lung cancer for the second time. So there was a spiculated nodule in my right lung, my upper lobe, the lower part of my upper lobe in my right lung. So the treatment plan on that, so that was a little nerve-wracking because I went to a surgeon, and even though it was a small tumor, because of where it was located, the only surgical option was to remove the rest of my lung. And because I learned that the middle lobe can't survive by itself. And I'm really active and fairly athletic, and that really wasn't an option. And my particular tumor, we felt confident, or Dr. LANFRANCO felt confident that it was malignant. So after several conversations, the decision was made to have radiation. So I had SBRT radiation on that tumor. So they couldn't biopsy it either because the risk of biopsy outweighed the benefit because they were so certain that it was malignant. And you can jump in if anything I'm saying is incorrect, but that's how I remember it. So I know we didn't biopsy it.
You've got it all perfectly.
And then from there, I was back to a 3-month follow-up, and then a 6-month follow-up. And I've never gone any longer than 6 months in the past, I'd say since my second diagnosis. So then 5 years after that, now we discover something else that's on my left lung, which I say my good lung. And so we watch it. And when you talked about the uncertainty part of it, it never goes away. It's always there. And I'm an action-oriented person, so I like when we can come up with a plan. If we have enough information that we can come up with a plan and do something about it. But when we're not sure what it is, and we have to wait 3 months, see if it's changed, wait another 3 months, it's not really where we want to do anything with it yet. That's really unnerving for me. And I've learned to just look at it and realize that worrying about it isn't going to change the outcome. We still don't have enough information to make a decision. The best decision is to wait and watch. So I can sit around for the next 3 months and worry about it, or I can just go live my life and worry about it when I need to worry about it. Right now, I'm not going to treat it. So we did that for I think 3 scans until it got to the point that everybody felt that something needed to be done. And this is a really great example of shared decision. I don't know if you want to go in that direction yet, Danielle.
Sure.
But I did not want surgery 18 months ago. And I was absolutely sure I was not going to go and have surgery because 18 years ago, it was really hard and it was really painful. And I had 2 surgeries. I had one that they found a malignant tumor, and the next year I had the exact same surgery, only thankfully it was benign, it was scar tissue. But it was a really hard, difficult situation. So I didn't want to have surgery again. And Dr. LANFRANCO was my coach. We talked about, there was ablation, there was radiation. I voted for radiation. I wanted radiation because it was so much easier 5 years ago. I was tired, for a couple of days, 10 days afterwards, that I could deal with, right? They keep cutting away your lungs. It's precious real estate. I wanted to keep it as long as I could. So surgery was not my first option. And Dr. LANFRANCO encouraged me to keep the door open to surgery. So I went and I spoke to my medical oncologist and I got his point of view. And then I spoke to the radiation oncologist and I got his point of view. And I spoke to another doctor. I'm not really sure what his role was, what his overall role was, but that was about ablation. So there were all these different treatments that I could have. And I took all the information and then I obtained all the answers, and I met with Dr. LANFRANCO and made the final decision with him. But walking in the door saying, okay, you were right, surgery is really the best option for me. And I ended up having surgery 18 months ago and had a wedge resection of my left lung. And it was a pretty incredible experience. I also got to participate in a clinical study during that surgery. And because of that, they found a second tumor, which was technically my 4th malignant tumor that didn't show up on any of my CAT scans. So, and they were able to remove both tumors, both nodules, in one wedge resection, and it didn't really impact my lung capacity, which was really important to me. So it's really hard and it's emotional and it can be frustrating to wait and see
Yeah. So, Terry Ann, I just want to recap and with a couple of takeaways. I mean, I think you did a good job describing, sort of the transition through this monitoring 3, 6, 12 months. And I know speaking with a lot of folks who have been diagnosed with lung cancer who are also, and even those who have been screened but are still in this monitoring process, the anxiety that comes with the extension, I guess, of the follow-ups. Like, oh, okay, well, are you sure we can go to 6 months now? Are you sure we can go to a year now? Because what if you put me on a year and 6 months from now and then there's something anyway, you know what I'm saying? And so I think there's a ton of anxiety that comes along with that, number one. Number two, you talked about the different surgical experiences you had. And I think it's very important for folks out there to know, not only in lung cancer in the last 15 years in particular, have we made huge advancements in the treatment realm, but in the technology realm as well. And so where 15 years ago plus, the majority of lung cancer surgeries were done through like a thoracotomy where they're cutting halfway across your back. Now, with the assistance of, video assisted thoracic surgery and or the Da Vinci or robotic assisted surgery or anything like that, the I say turnaround time, and I mean turnaround from you going in, having your surgery and being back up on your feet is so much shorter. So I think it's always important to keep up with what's happening, not just from a treatment, from a drug standpoint, but from how we're monitoring, how we are discovering, to your point, that study that you and Dr. LANFRANCO made the decision together to not only am I having, this surgery, but I want to enter this study, and lo and behold, here's this other nodule that we wouldn't have found. That's it. Those are all advancements that are benefiting you. And that's a very long-winded way of me saying, and I guess we're asking, because I know you to be a very educated patient. You are someone who, took the bull by the horns from very early on and decided you weren't going to let this cancer control you. You were going to control it, and you were going to make decisions, and you were going to pull together teams to make these decisions with. And I guess my question is not only how important is that to you, and has it been in your experience, but how important is it for you to share your story with other people in hopes that they will also, educate and empower themselves so they can make these informed decisions?
It's very important to me. I will say one thing though, I will make one correction, is I don't think I control the cancer. I can only control how I react to it, and how I react to it is knowing everything I can know about it. And I do encourage people to be their own advocates and speak up. And I'm not just saying this because you're on the call, but my medical team is amazing. I ask a million questions and run through a million different scenarios. And for me, it's very important to understand, because everybody's invested in the outcome, but no one's going to be as invested in my lungs as I am, and so I want to know everything there is to know. I want to ask a lot of questions. I want to understand what the best treatment options are. So I encourage patients to get out there and talk to their doctors, educate themselves. And it's so different now than when I was first diagnosed. I wasn't worried when I was first diagnosed. I didn't think there was anything to worry about until I was actually diagnosed with lung cancer. And then I went on the internet and I was paralyzed because there was nothing there for me to find. And my doctor said, get off the internet. You're not a statistic. And the statistics for lung cancer 18 years ago, I wasn't going to be here. Early detection is key. So I also encourage people that are afraid to go and get scanned to talk to them about getting scanned, because I have a great life and I've had lung cancer 3 times. And it's because it was caught early and treated. and it's not, it doesn't have to be the death sentence everybody thinks it is. If you can catch it, the earlier you can catch it, the better it is. So I speak to patients and I talk to people, A, for awareness, it's really important to me, and B, I want to show them what's possible. And I'm just so grateful for where I'm at. And I'm so grateful for my experiences. And I want other people to have this experience. And there are more of us out there to be found. And I want to help find them and let them have great outcomes too.
Yeah. Thank you, Terry. And I appreciate that so much. And if I insinuated that you could control your cancer, it's, huh? It's most
Sorry, that
definitely
was beautiful.
It it really was. It really was. And I don't want you to think that I think you can control your cancer. I guess what I was trying to say is you were controlling how you were dealing with the diagnosis, which you said way more beautifully than I. And I think it all points back to um, educating and empowering yourself and finding amazing healthcare teams and multidisciplinary teams that will work with you on that shared decision and decision making. And for those of you who may not know what we mean when we say that, it's you understanding what your options are and having the conversations with your healthcare providers about what the best options are for you. So, and there's a risk reward sort of piece to all of that, right?
Mm-hmm.
These are the benefits of doing it this way, but these are also the risks. And you being a part of that decision making, I think, is a whole lot easier when you're somebody who's actively involved in not only the diagnosis but the treatment, the treatments that follow. And somebody asked a question online about your risk factors, Terry, and I think maybe you just reiterate the incidental way in which you were diagnosed and the family history, and then Dr. LANFRANCO, we can talk about how family history is not technically a qualifying criteria right now.
So mine was found because I was having chest pressure. My doctor told me to go to the ER. So I went in for what they thought was, cardiac issues, and that's what I was admitted for. And the nodule was incidental. Oh, and by the way, before we, release you, we want to talk to you about this little nodule we found in your lung. So I would not have. I did smoke, so I do have that risk. And I would not have qualified for screening. So I didn't have the smoking history to qualify for screening. And I think so. I think it was the combination of that and my age that is why my medical team at the time didn't think that it was going to turn out to be malignant.
Yeah, thank you. And I know we touched on your family history, and this is where I'd love to hear from Dr. LANFRANCO, because I too have a very strong family history of lung cancer diagnosis, all on the maternal side of my family, straight up to my great grandfather. And so, can you talk a little bit about that? I mean, and that's a big, this big sort of, light bulb sort of bubble where I think a lot of people are having conversations, but really haven't identified what the tie exactly is, similar to what we find maybe in like a BRCA gene. So if you can describe that a little bit.
That's a great question. So the genetics in lung cancer and inheritance are murky. To be very precise, murky. So we know that if you have let me just say it's not like inheriting the BRCA gene or inheriting blonde hair, or blue eyes, or anything like that. It's much more complex, and it's probably more along the lines of inheriting a predisposition for lung cancer. So there's something in the genetic code of these families that predisposes them to developing cancer if they encounter the right trigger, cigarette smoking, say. That's the most common. And so we find that lung cancers do travel in families, but it's usually not just, it's usually associated with smoking. So if you have a relative who has lung cancer and you smoke, you're more likely to get lung cancer. It doesn't mean, though, that if you have a relative that has lung cancer and you don't smoke, that you're likely to get lung cancer. It doesn't travel like that. You have to have that extra insult.
Yeah, it's so interesting because I know talking with folks over the last couple of decades, and one family in particular, I think there's this whole group of people out there that are like, well, what about me, right? Because I am the sixth person in my family to get lung cancer. We're never smokers. We don't live in Philadelphia, where there's all this like why us and what about us? And I think, when I look at it like that, and there's been some research, but I think it's another opportunity for discovery so that we can figure out for the sort of what about me, group of folks who do wind up diagnosed. They think they've done all the right things. They live this healthy lifestyle, and they get
Yeah,
lung
I
cancer.
think that's a hugely important topic. So two points related to that. One is 15% of all lung cancers happen in never smokers. But the public policy is really a result that most lung cancer victims are smokers. And so there's this stigma associated with it, which is tragic and stupid and means that there hasn't been the appropriate amount of research dollars pumped into lung cancer, despite the
Yeah,
fact that it kills more people than any other cancer out there.
Yeah, this is such a sticking point for me, and it's one of those things that makes like smoke come out of my ears because no literal pun intended. But I think, you look at just lung cancer in general, number one cancer killer, never smoking lung cancer, in spite of that 15% number, is still a lot of people, not just nationally, but globally. And it's still number 5 in the list of cancers for top killers. And so, unless that data has changed since I last looked, which was probably, I don't know, couple of years ago. But the number 5 top cancer killer is never smoking lung cancer. And the fact, and this is where this outrage, where I think we've done a lot of great things, but where this outrage kind of stems from how have we let it go this long without directing the dollars towards a better understanding of this disease? And now it's finally happening, and we're here. And I can quit my rant because I'm also watching The Time. And I know we've talked a little bit about determining when a biopsy should be done. One of the things we didn't jump into are the multiple sort of ways with which that biopsy can be done. So, can you, Dr. LANFRANCO, give us a high sort of overview of some of the different options for ultrasound? Because I think people are also afraid, or not ultrasound, of biopsy, because I think people are also afraid of this procedure as well.
Yeah, absolutely. I will say that for most people, that these diagnostic procedures wind up being a distant memory. So even though they're scary when you're approaching them, 5 years afterwards, you're like, oh, I experienced this. Oh, you did a biopsy on me 3 years ago? I don't remember. So it happens that people forget about it. It's scary when you're confronting it the first time, but it's part of the process, and usually it goes smoothly, and people tolerate them well. So if we're talking about lung nodules, there's really 3 ways to get tissue. And in lung cancer, tissue is imperative, especially now, because we need to know the genetic markers of the tumor. We need to know its immunophenotype, meaning how does that tumor interact with your specific immune system. And we need to have enough of that material to do. It's a stunning number of tests we run on that tissue. So being able to get enough tissue and provide all this information is part of the decision-making process of which biopsy to pursue. But generally, there's 3 ways to get tissue from the lung. And which way we go is determined in a lot of ways. One is overall or underlying lung health, accessibility of the nodule, and whether a person would tolerate surgery or not. So 3 ways are: one is a transthoracic needle biopsy. So that's where you see a radiologist or an interventional radiologist. They usually lay you on a CAT scan table. and they numb up your skin, and they put a needle from the outside into your lung, into the nodule, and they collect material to send to pathology. The second way is bronchoscopy, and bronchoscopy is sort of a generic term. Under bronchoscopy, we talk about a lot of different technologies. At the core of it, though, bronchoscopy is really just a scope like people get colonoscopy, or they get people looking in their esophagus. It's that same technology, it's just smaller, so it fits in the airways. So it's a long, skinny tube with a light and a camera and a working channel. And then we've got a scope that has ultrasound on the tip of it that lets us look outside of the airways, so we can identify the structures in the middle of the chest and do ultrasound-guided biopsies. We've got ultrasound probes that are about the size of a spaghetti noodle that we can slide out into the lung to get pictures of nodules and help us direct our biopsies. We've got a variety of navigation devices that we can use. There's virtual bronchoscopy, which is just GPS for the lung. It just tells the doc where to turn and put the scope. We've got electromagnetic navigation, which is GPS attached to like this electromagnet that it tells a computer where the nodule is at in space and where your instruments are at in space, so you have a more precise view and targeting of nodules. And then the most recent innovation is robotic bronchoscopy, which it's still just a bronchoscope. It's still just a skinny tube that goes down in your airways. But the way we control that bronchoscope is very different, and it's much more precise than the traditional bronchoscopes. So just to bore you guys with technicalities, so a regular standard bronchoscope is, the doc's controlling it outside of your body, just turning their wrist and pressing their thumb. But the robot actually is controlled inside at the tip using the robotic technology. So it's fascinating. That's also often coupled with sorry, it's also often coupled with other technologies. So one robot uses electromagnetic navigation. Another robot uses this light emitting diodes to do something called shape sensing, which is, the tech is unbelievable. And then we're actually also combining the robots with something called cone beam CT scanning. So we can actually do CT scans while we're doing the procedures to make it even more precise. So that's a very long-winded explanation of bronchoscopy space, but just there's all kinds of stuff that's out there. And then the third way to get a biopsy of the lung is surgery. And so just like Terry Ann's experience, if there's a nodule that's amenable to a wedge biopsy, they'll go in they'll do a wedge while the patient's still asleep on the table. They'll take it to the pathologist. They'll do a frozen section. So they'll look at the tissue in real time. If it's cancer, they'll come back and do the cancer surgery, which is removing the lobe. If it's not cancer, they close and wake you up. So those are the three ways to get a biopsy, and the decision which path to take can be quite complex.
Yeah, it sounds very complex, and I too agree with you on the fascination piece around the technology. I've been following sort of the growth of this technology space for a long time. I have a dear friend who's an interventional pulmonologist out here in California, down in Mountain View, and with the permission of patients, of course, I've been invited into the sort of operatory and watched some of this happen in real time. And, fascinating doesn't even begin to cover it from my perspective. But I think when we really look back and think about it, and particularly with GoTo, and one of our main goals is to increase the rates of people being properly diagnosed, including upfront comprehensive biomarker testing. The only way we're going to do that is to gain access and get access to quality and quantity of tissue that's appropriate for this testing. And so I am unbelievably blown away by the way that we can do this now. And we need to do it the first time, I should say that, because I know there's a lot of patients who have to go in for multiple biopsies because they didn't get the quality. It was either necrotic or dead tissue, or just we didn't get enough. And so I think this is, yes, I geek out on this too. So I'm right there with you. Okay, I do want to be mindful of time. Also, I know we started a little late and we're running at about the hour mark right now. I know it's getting late on the East Coast, so thank you both. And I think what I'd like to close with is really from both of you, any take home points. Like, what do you really want the folks watching this to take away from the information that we were able to provide tonight? Terry Ann, let's start with you.
I think it's so important to, well, I don't want to tell people what type of patient to be. They need to be what's ever going to work best for them. But it's really empowering if you can educate yourself, understand what's going on, ask questions, because ultimately the decision on the direction that you're going to go in is yours. Your medical team can only advise you. You're the one that's going to make the decision, the final decision on what direction to go in, most likely. So don't be afraid to ask questions and get involved and educate yourself. And GoTo's website is great I think you guys even have a list of questions on there that people can take with them to their doctor to ask. So
Yeah.
I would say educate yourself and ask a lot of questions.
Yeah, thanks, Terry Ann. And I will too plug GoTo in this realm. And we have a vast, comprehensive library of educational materials that are really geared towards the layperson. So an easy to understand, palatable sort of bits of information. Our helpline, which I think we've been kind of flashing back and forth throughout this program, is really a front door, sort of the gateway in to GoTo, where you can really find out, and you can not only get any and all questions answered. If we don't have them, we have the resources and or the people to connect you with to get them for you. And there are no stupid questions. But it really is the gateway into all of the other different support and education programs that we have. And so again, a sort of shameless plug there for GoTo and our patient support programs. But Dr. LANFRANCO, what about you? What about your, what's your high level sort of takeaway that you want people to really bring home with them tonight?
A couple. One is I agree with Terry Ann. It's really important to if you're not looking it up yourself, at least find some resource that can help you ask the right questions. Asking the right questions is so important. Two, I would say seeing somebody that deals with these things a lot is important. So not to knock, the folks out in places that don't see a lot of lung nodules. I know there's lots of pulmonologists that don't see them that often. But if you're one of the patients that has a lung nodule, it can be incredibly helpful to find somebody in your community that sees and deals with a lot of lung nodules. It really is just a volume thing. The more you see, the more you learn, the more you do, the more you know. And it can be incredibly important in a patient's journey to have somebody with that experience in their corner. And then the third point is, well, you said it at the beginning, but I'm going to say it again. Screen, please screen. Early detection saves lives. Please encourage anybody you know who smokes, quit and get screened.
Yeah, amen. Yeah, amen to that. And I know, when we think about this program, and we do talk about screening quite a bit in this programming, and sometimes it feels a little counterproductive because most of the people watching, not all, but most, have already been diagnosed. So they're like, what do I need to know, right? I've already got lung cancer. But what I like to tell folks that are watching, and I will say it over and over and over and over and over again until we see that 4 or 5% of people who actually qualify getting screened, until we see that number increase, I'm going to keep saying it. You are the best sort of billboard for the importance of screening. You have friends, you have neighbors, you have loved ones, you have grocery store clerks. Shout it from the rooftops, because I think, a lot of times it's just a matter of people not knowing that it's available, on top of them being afraid. So please, 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 yes, get screened. And I will reiterate the second opinion, and I will let folks know, because quite often it's hard. People are like, well, I really like my doctor and I really trust my doctor, and I understand and have a great deal of respect for that. I think a second opinion doesn't mean you don't have to not like your doctor. And quite often, even if there's nobody locally who maybe is an expert in lung nodules or diagnostics or treatment, if there's an opportunity for you to go remotely, get a second opinion, more often than not, that second opinion doctor will work with your town, your hometown doc, to generate treatment plans that are best for you. So it does not have to be one or the other. It can be a combined approach and effort into ensuring that you're getting the best possible care for your cancer. Okay.
Danielle,
Go ahead,
can
Terry.
I just say one more thing on screening?
Yeah, of
And
course.
I think it's important because we do talk about this. Screening is not just one and done. Follow-up is critical, and we can have these screening programs, but if something's found, follow up on it, and follow up for as long as someone tells you to. There's a good chance I wouldn't be sitting on this call right now had I not followed up 18 years ago. So it's not just a one and done screening, it's following it and following the nodule.
Such an
And I would just
important.
add, even if you don't have something on the screen, you're not off the hook.
Yeah.
It's a process.
Yep, it is a process. And I look at it, it's no different than mammograms or even colonoscopies to some extent. You don't just go get one and then never go back again. There is a method to the madness, so trust the process, because early detection is key for survival. It really, really is. I do want to, start by thanking you. I'm going to thank you between now and the end of this programming, which will only be a couple of minutes, I promise. But I do want to do a little bit of housekeeping. We are only a week and a half, 2 weeks away from Lung Cancer Awareness Month, which is really this community's opportunity to shine, to generate awareness, and to shout from the rooftops about everything from screening and early detection through upfront biomarker testing, treatment options, personalized medicine. Did you know, right? Just really generating awareness around it. And one of the things that we do at GoTo is our Shine a Light program. Shine a Light on lung cancer is a free Lung Cancer Awareness Month program where healthcare facilities can host events or even educational tables within their centers. It's free to host. It's free for participants to attend. So if you would, be interested in maybe your local healthcare facility potentially hosting a Shine a Light, what we do is we provide all the digital resources to help plan and promote, as well as physical toolkits and education materials and giveaways to let these centers know that they are thinking about our lung cancer community at risk and diagnosed. So far, and I'm kind of stoked on this, we have 170 Shine a Lights in 48 states. So if you live in Rhode Island or Nevada, we need you to jump on board with this. But not only are we in 28 states, but this year we are also in Italy, Ireland, and Africa. So we're really generating awareness on a global way through this Shine a Light program. So anything you can do to help support within your community, we really, really appreciate it. On top of that, next month's living room, we've got a special edition coming up. Our Center of Excellence Summit is coming up at the end of the month here. So be on the lookout for communications around the special edition programming that we will be hosting live from Nashville, Tennessee. It will be our first on the road and actually our first live in-person event since COVID. So we're really, really excited to get out and be doing that. And it's really about financing cancer care. And financial toxicities and what that really means. When we say financial toxicity, what does that mean? Because it's not always just what we think. It's not always about the money to pay for your care itself, but the money to kind of support your own self while you are caring for yourself during your cancer treatments. November 15th is part one of a two-part series. And it's really around health equity. I think a lot of us have heard that sort of buzz phrase, lingering around for quite a while now. And we really thought it might make sense to step back and really define what health equity is. Because it too, just like the financial toxicity piece, is not just one thing. It's not just one one, sort of piece of the pie that needs to be figured out. There's multiple pieces, and it is a multifaceted issue. So we are going to be hosting a Health Equity 101. What you need to know about health equity, where it comes from, what we mean when we say it, and what you can do to play a role in helping to generate, better health equity and outcomes for folks in some of the more disparate sub parts of the country. Anyway, to get regular programming or regular information and updates on this programming, as always, you guys could please consider joining our patient and caregiver community. The URL is coming up right there on the bottom. This will really help us to remind you about this programming so you can decide what you do and do not want to chime into live and or post live. Again, I want to give a huge, huge thank you to our panelists, all of you watching live or those who will come back and watch post live. Penn Media on the back end of this, who is helping us to bring this programming to you. Michelle Zay, who's like the right arm of this programming, and is also on the back end monitoring every month. And the entire GoTo team, really, for all of their support and all of the work that they do for this community. And as always, our generous supporters: Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Thank you, thank you, thank you for continuing to support this programming. And with that, we will hope to see you guys next month. Everybody have a great evening, and until then.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.